right, so today we're going to talk about chapter 44, metabolism. So that is going to be our drugs for pituitary and adrenal disorders. So we're going to examine the uses of exogenous pituitary and adrenal hormones in the care of patients with selected pituitary and or adrenal disorders, and plan nursing care to administer medications for patients with these disorders. Okay, so this is chapter 44, but we're going to admit anything to do with the thyroid, hypo, Graves, all that. Don't worry about it. Just pituitary and adrenal. Okay. So why would you need hormone pharmacotherapy? Because your hormones aren't working. So hormones are used as replacement therapy, anti-neoplastics, as we know, natural therapeutic effects, exaggerated response or suppression of the body's defenses. They sometimes the hormone blockers inhibit actions of the certain hormones, and the hormones we're going to talk about are in the pituitary and the thalamus and the adrenal glands, but we'll get to adrenal in a minute. So the hypothalamus, the whole job is it secretes a releasing hormone. The releasing hormone goes to the pituitary and says, hey, release these hormones. Okay, so the hypothalamus kind of controls what the pituitary is doing. The anterior, which is the front of the pituitary, that secretes your adrenocorticotropic hormones, your TSH, your growth hormone, your prolactin, follicle stimulus, the FSH, and LH. The posterior does your antidiuretic and your oxytocin. Not super important to know which ones do what, because we're going to talk about all these kind of disorders together. All right, so this is a table in the book. I really liked it because it just kind of simplified it all. It made it a lot easier to understand, because the book did not do a great job of explaining everything. It just has random drugs and we're like, I don't even know what this treats. So this is the best way I can figure it out. So, and I added some stuff to it. Adrenal cortex, we're going to talk about that at the end. Okay, so the adrenal cortex emits corticosteroids. When you have too many, it's Cushing's. When you have not enough, it's Addison's. And then we'll talk about those drugs at the end. Okay. Except for we'll talk about those drugs then. Pituitary does three that we're going to talk about: the antidiuretic hormone, the growth hormone, and the oxytocin. So the antidiuretic hormone, if it does too much, it's SIADH, which is a syndrome of inappropriate antidiuretic hormone. It's doing too much. It's secreting too much. If it's not doing enough, it's diabetes insipidus. For the growth hormone, it is, and we're going to talk about what this acromegaly is. If it's hypersecretion, so it's too much growth hormone, it's acromegaly, which is only in adults. And then the hyposecretion is small stature, and that's usually only in children. Okay. And so then you add all these drugs, and these are the drugs we're going to talk about. Okay. So growth hormones. So our growth hormones in the pituitary hormones, or the growth hormones, it's also called somatropin, which is the name of one of the drugs. Okay, easy peasy, right? That is literally the name of one of the drugs. So we use somatropin only for somatropin, and the one other one is the only mecaserin, are the only ones we use for hyposecretion. So these are for small stature children. They're children, keyword children. Okay. The other keyword is growth plates. Okay. Which is going to be important to know when we get to acromegaly. But these we can only give growth hormone, or growth hormone that stimulates to the production of growth hormone, if the plates, the bone plates, are not fused. Okay. Your growth plates. So if they do an x-ray and your growth plates are fused, so you've fully grown as much as you're going to, there's nothing they can do about it. You're just going to be short. If it's early enough and we catch it early enough and the growth plates have not fused, they can give you the growth hormone. Okay. But there's a lot of other criteria besides that, but that's the biggest one. Okay. Because the whole point of the growth hormone is to make you grow. Okay. If my bones are already fused, I'm going to have bone abnormalities. Okay. So I can't have that fusion and get somatropin. So somatropin is a growth hormone. Okay, some common side, it's an injection, so common side effects are the injection site pain. You can have high blood sugar with this, okay? Because it needs energy to grow, so it can actually make you hyperglycemic, right? Arthralgia, which is joint pain, right? Myalgia, muscle pain because I'm growing. Abdominal pain, you can have an ear infection like otitis media, headache, bronchitis, hypothyroidism, high blood pressure, okay? And flu-like symptoms, things like that. There's one very big side effect, which is respiratory impairment, but it's only for people with Prader-Willi syndrome, okay? This also can cause diabetes because of the hyperglycemia. Pancreatitis, which is that extreme abdominal pain, and my pancreas is inflamed. It's usually vomiting as well. Scoliosis of the spine, because it's growing so much, it just warps, okay? And then it can also cause intracranial heat tumors. So what am I going to do for someone that's going to take somatropin? I'm going to monitor their blood sugar, monitor their high blood pressure, monitor their blood pressure, period. Monitor for flu-like symptoms, signs, symptoms of hypothyroidism, and pancreatitis. The other thing that's important is that if they do have that Prader-Willi syndrome, we are monitoring for respiratory impairments, okay? So then when we get to acromegaly, now a lot of medicines, treat the acromegaly, but I'm going to talk about one specifically. And there's other ones in your drug cabinet that you're still responsible for. But acromegaly is when you have excess of a growth hormone. It's caused by a tumor, okay? The tumor secretes growth hormones. Now we have excess. And the reason why we only do this in adults is because you don't know if children have it because of growth plates, right? So once the growth plates are fused and you're an adult and you have excess growth hormone, what's going to happen? You're going to start having that bone abnormality. So you start having like, what's it called? Like disformed hands, your face, disformed bones in your arms and things like that. It's like it's almost like knots and like they start crunching up, okay? You can also have a slanted forehead, so like it kind of goes like this. A large protruding nose is another one. There's lots of symptoms about it, but it's mainly bone related, okay? So bromocriptine is one we use for acromegaly. The mechanism of action, just ignore the mechanism of action, okay? Because it's really weird. So it inhibits prolactin and, increases your dopamine. So they use it for prolactin secreting tumors. So it stops the prolactin and so it'll get smaller, but it actually increases your growth hormone. And it's really weird, but if you have acromegaly, it will actually paradoxically lower your growth hormone. Weird, right? So it has nothing to do with the prolactin and the dopamine for this. We are talking about the paradoxical reaction if you give this to someone with acromegaly, and it will cause a decrease in their growth hormone, okay? So the other thing that we want to talk about is some side effects. Orthostatic hypotension, nausea, vomiting, fatigue, dizziness, headache. All right, as kind of all go along with the orthostatic hypotension, right? Now the bigger ones are shock. You can have a heart attack. You can have a cerebral ischemia. You can have it can actually cause the tumors to grow, especially the pituitary tumors to grow at first, okay? Which is a big deal, okay? It's growing tumor. All right, so we want to take it with meals, advise other types of birth control because of the prolactin, alterations, rise slowly, and then monitor for, what's it called? Monitor for nerve suppression. So because the pituitary, all the cranial nerves, they go back and then they cross over and they kind of, where they're at to the pituitary, there's a lot of nerves around the pituitary. So if it grows, it can like kind of occlude those specific cranial nerves. So most cranial nerves do movement, like of your face, of your eyes, of your ears, nose, mouth, whatever. And then some of them do your senses, like let you see, let you smell, taste, hear. So those are the symptoms. If I have nerve suppression. My face might be paralyzed on that side or whatever, whichever one I suppressed. Or I may lose one of my senses, sight, smell, no, taste, okay? So that's one of the medications I use for acromegaly. So now we're into antidiuretic hormone. That's the other pituitary hormone that we need to worry about. Okay, so antidiuretic hormone maintains fluid balance. It conserves water in the body. If you don't remember, if it works too much, it's SIADH, and if it works not enough, it's diabetes insipidus. So diabetes insipidus is caused by deficiency of ADH. Most common form of ADH is desmopressin, which is the name of the drug to treat it. Easy peasy, right? So when I don't have enough of the antidiuretic hormone conserves water. So my body is not conserving water, and it is peeing incessantly, okay? I'm urinating so much. That is like one of the biggest symptoms, okay? So I just can't keep up with how much I'm peeing, and I get dehydrated, all right? So diabetes insipidus, we have desmopressin and vasopressin, both in impressin, okay? There's also lipopressin, but the two most important ones, the desmo and the vaso, okay? Those are the most common ones we use. So the vasopressin reabsorbs water. We're going to talk about desmopressin on the next slide, but the vasopressin reabsorbs water in the kidneys. Side effects are tremors, pallor, nausea, vomiting, water retention, and water intoxication, angina, acute heart attack, gangrene, anaphylaxis, cardiac arrest. Okay, so if it's working too good, so if it's conserving too much water, I can have water retention, okay? The other thing we want to talk about is, what am I going to do for this patient that's on vasopressin? Well, I definitely need to monitor the cardiac status, that's EKG, heart rate, blood pressure, because I do not want them to have a heart attack or go into cardiac arrest, okay? One of the biggest diagnosis tools for diabetes insipidus is your urine specific gravity. So I'm not conserving water, so I'm peeing out water. So a lot of water in my pee. I'm going to have a very diluted urine specific gravity. So I have to monitor their urine specific gravity and their INO to make sure that it's working, that the vasopressin is working, and or if it's not, okay, if it's getting worse. I want to monitor for the edema, because that means I'm doing some of the water retention, right? But you also want to monitor for dehydration, because then it's still not working, okay? Okay, we also want to tell people to take vasopressin to drink 1 to 2 glasses of water with administration. That's all. Otherwise, an empty stomach, okay? So you do have to drink water while taking these medications, but as we get to desmopressin, we're going to talk about how much water. So desmopressin has lots of different routes. IN, intranasal, IV, PO, sub-Q, sublingual, okay? It's for the diabetes insipidus. It's for insufficient ADH secretion, bleeding with hemophilia A, von Willebrand's type 1, which is a type of hemophilia, nocturnal enuresis, so I'm wetting the bed. So this is a synthetic form of ADH to increase your absorption of water. It works pretty fast, IV, it's pretty immediate onset. So, and even the PO is 1 hour. That's pretty fast. All right, so things we want to monitor for and look out for with the adverse effects: water intoxication, which looks like drowsiness, headache, listlessness, which is like I'm not very awake, I'm very lethargic, confusion, and eventually coma. Headache, nausea, abdominal pain and cramping, facial flushing. You can have high blood pressure because if I've taken too much water, we know that can make my blood pressure high, right? Hypervolemia. And pain or swelling at the injection site, if it's an injection site, right? Intranasal, you can have nasal congestion, rhinitis, you can have a nosebleed. Pretty standard with intranasal administrations. IV, you don't want to give it more frequently than every 48 hours, so every other day, because a tolerance can be acquired, and then it's not going to work. Then we have no other options, okay? Black box warning. hyponatremia, severe or life-threatening. I have so much water that it has made my salt cannot keep up, so it's low and have all this extra dilution. So we have to monitor for hyponatremia, okay? And look out, make sure they don't have hyponatremia before we give it. All right. So drugs we want to avoid: chlorpromamide, NSAIDs, lithium, alcohol, heparin, epinephrine. As we know, lithium and alcohol can affects water intoxication and sodium. Unknown foods, the treatment overdose is symptoms are severe water intoxication. The treatment is water restriction and osmotic diuretics. Okay. So diabetes insipidus caused by chronic or acute kidney disease is a contraindication. Cardiovascular, CAD, high blood pressure, because we don't want to make it worse, right? We already have some kind of cardiovascular disease. We don't want to make it worse. Hyponatremia, because we will make the hyponatremia much worse, and we do not want to send people into seizures and death, okay? If you've had a clot, caution with young children or older adults who are more prone to water intoxication and hyponatremia. So, once again, monitor those sodium levels, okay? Restrict fluids after the IV injection and monitor for water intoxication. So this is already going to tell you to conserve all the water you have. If we drink more, a bunch more, so it says on the nursing interventions, restrict fluids, drink only enough to satisfy thirst. That means that they're not on like a no liquid diet. It just means if they're thirsty, let them drink. Otherwise, leave it alone. You don't need any extra water, just a little bit, okay? Because we don't want to give all that water to the patient, then have it be conserved and then become hyponatremic or water intoxicated, okay? If we're given the intranasal, we're monitoring the nasal mucosa. We're monitoring for water intoxication. We're monitoring their INO, their weight, and their blood pressure, okay? So also, if they're taking this medication, they really need to wear a medical ID band. All right, so now we're on to the adrenals. So the adrenals secrete the glucocorticoids, mineral corticoids, and then the gonadotropins. So glucocorticoids are the mobilize the body for long-term stress, influence carbohydrate, lipid, and protein metabolism. The mineral corticoid, I'm not going to keep saying this. The mineral ones promote sodium reabsorption and potassium secretion. And the gonadotropin ones, mostly male sex hormones and the androgens. Okay. There's even more. There's the CRF, which is the adrenocorticotropic hormone that's secreted by the pituitary, tells the adrenals to secrete this, okay? They release the corticosteroids. When cortisol levels rise, negative feedback mechanism shuts off further release of it. But now we're going to talk about when that mechanism doesn't work, okay? So Addison's disease is when you have an insufficiency of the corticosteroids, okay? So you don't have any corticosteroids or mineral corticosteroids. So this is like a little picture. Addison's, and we'll get to the opposite of Addison's, is very hard to remember. So try to remember this picture, okay? We've got hypoglycemia, postural hypertension, weight loss, so we're skinny, okay? Addison is very skinny. Weak GI disturbances, and we have changes in the distribution of body hair. You see, this is a woman that has a mustache, okay? And then they have that bronze skin. So nausea, vomiting, lethargy, confusion, coma, low cortisol levels, accompanied by high plasma ACTH levels, okay? So that's the adrenocorticotropic hormone. That's the ACTH. So how do we treat Addison's? We're going to give them what they lack. If they don't have any steroids, we're going to give them steroids, okay? Plain and simple. Primary use is to diagnose adrenal disorders. With this specific one, it's given parentally, and you're going to have side effects just like you would to every other medicine. How do we treat it? For primary Addison's or secondary adrenocortical insufficiency, we give corticosteroids. We also give corticosteroids for a bunch of other reasons like infection, allergies, neoplasms, and stuff like that. But hydrocortisone is what we use to treat Addison's. Okay, so that's what we're going to focus on this for. Don't worry about it all for the neoplasms and infection and things like that. We're talking about it for Addison's. Okay, so this is PO, IV, IM, rectal, or topical. It's a corticosteroid, so you can have lots of different routes. It's for adrenocortical insufficiency, inflammation, allergic disorders, joint inflammation. It's a synthetic corticosteroid. So the biggest side effect, what we want to watch out for, is Cushing's, which is the opposite of Addison's. I have too much corticosteroids, and now it is affecting my body. And we're going to get into signs and symptoms of that on the next couple slides, okay? So prolonged use, we can have the Cushing's, sodium and fluid retention, we know that. Insomnia, anxiety, headache, vertigo, confusion, depression, high blood pressure, tachycardia, peptic ulcers with long-term therapy. One thing that's not mentioned is the, all steroids can sometimes, especially with long-term use, can make your bones weak and make you go into osteoporosis or, deplete your calcium. So we definitely want to add that to adverse effects. Well, there's a lot of drugs we want to avoid because of the side effects. These can make them worse, like barbiturates, phenytoin, rifampin, estrogen, NSAIDs. Also want to, avoid anticholinesterases, diuretics, decreases the immune response to vaccines and toxoids. So lab tests, it can increase your serum glucose, can increase your cholesterol, your sodium, your uric acid, and your calcium, and decrease your potassium and your thyroids. Okay, so foods we want to avoid are senna, cascara, buckthorn. No overdose treatment. It's a contraindication if you use it with a hypersensitivity to this drug, have a known infection, you have diabetes, not just because it'll cause hyperglycemia, but also because it can also cause delayed wound healing. And if you have diabetes, you already have delayed wound healing. Osteoporosis, psychosis, liver disease, hypothyroidism. We want to take the medications at the same time every day, take the oral form with food. If it's taken more than 2 weeks, discontinue it gradually. But if you have Addison's, you're on it for a very long time. It's not a short-term thing. Monitor their blood pressure, monitor their weight, monitor their electrolytes and their blood sugar. Monitor for Cushing's, and this is like some of the symptoms: the moon face, the buffalo hump, central obesity, thinning hair, high blood pressure. Monitor for signs and symptoms of infection, and make sure your patient knows this is sometimes can mask the signs and symptoms of infection, right? Give a low sodium diet with high potassium and protein. Teach about increased bruising and monitor for stress and signs of trauma. That's a big one. So we know that stress, usually you have more steroids, right? That's because steroids increase things, right? So if you get stressed and my fight or flight's not going to be activated because I have Addison's, I have a problem. Or I'm going to use up all the drug that you gave me, and then I'm not going to be able to fix my Addison's because I'm stressed out. Okay, so this is a big deal. Trauma too, because it'll stress your body out. If my body is already using all the steroids to fight this stress, to fight this trauma, it can't fix my Addison's, okay? That's why it's important to monitor for stress and to tell them about low stress things. We also want to tell them about the low sodium diet is because of the fluid retention and the sodium retention. We also want to tell them that it does not increase wound healing, right? We talked about that. It can decrease wound healing and decrease healing in general, okay? So then we have our anti-adrenal drugs. These are the ones we use to treat severe Cushing's. Now we're in Cushing's, okay? Occurs with prolonged glucocorticoid therapy, inhibits corticosteroid synthesis. It is not curative, and it's usually limited to 3 months. So Cushing's, this is a high level of corticosteroids in the body for a prolonged period of time from hypersecretion of hormones due to tumors or long-term therapy. So this is what the Cushings look like. So when they said, when they were talking about the buffalo hump, it's not a mean thing. It's literally like, it's like a hump on their back. It's very pronounced, okay? So you can have personality changes, high blood sugar, moon face, which also sounds like it's derogatory, but it means like, it's not just a round face, it is an extra round face. Like it's just, you're like, something is not right there, okay? It's not normal round face, okay? You can have CNS irritability, increased susceptibility to infection, nausea and vomiting. Sodium and fluid retention, gynecomastia, thin extremities, fat deposits on the face, back, and the back of the shoulders, which is that hump. Okay, GI distress. With females, you can have the hirsutism, thin skin, purple striae, which are like stretch marks, bruising, petechiae, osteoporosis. So that is because it's the opposite. It's basically excess corticosteroids. So we already went over the signs and symptoms. If they weren't too good, that's Cushing's. Okay, in this everything we just talked about. All right. So we talked about this: the buffalo hump, the moon face. We already said all this. Treatment causes. Treat the cause. So if it's excess corticosteroid therapy, stop the corticosteroids. If it's from a tumor, figure out how to get the tumor out, or figure out what kind of chemo we need to suppress the tumor. These are other drugs that they use to suppress the corticosteroid therapy, if it'll like reverse corticosteroids. This one we've already talked about. This one is in your drug cabinet too, is for pituitary hormones. So if you want to read up on that one. But that's basically all of the pituitary and adrenal insufficiencies. It's not exactly easy because we're talking about hormones, not so much metabolism, but study the drug cabinet, go back to that table 44.1, and it'll help kind of differentiate what we're talking about, okay? If you have any questions, put them in the discussion board. Email me if you need to, and good luck.